Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is integrating social care into primary care. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan. How are you doing?
Good. It's great to be with you, Faisel.
It's good to be back again. You know, in my house, Tuesday nights are, I don't know about your home, but in our home, it's Taco Tuesdays. And, and I barely made it on show tonight. The cleanup can always be variable. You just never know what's going to happen. Before we welcome the guests, you know, my kids, especially my two younger ones, are 8 and 4, so it's always a disaster.
Right.
Well,
Yeah.
I'm very excited about tonight's topic. Obviously, it's something that we're both very passionate about. And we have like one of the leading experts in the country joining us tonight to talk about this topic. So without further ado, let's welcome Dr. Bob Phillips. Bob, welcome to the show.
Faisel, so glad to be with you. Thank you so much. And I wish I'd had a chance to have tacos with you.
Well, you come to Tampa, believe me, you come to Tampa, we can make it happen. Well, welcome. I would love to hear about your story. You know, you're a family medicine doctor. You've had an incredible career, and you're doing amazing things right now. You know, we have a shortage, obviously, of primary care. Internal medicine. Most of the internal medicine residents aren't pursuing primary care. Even when we have family medicine residents are doing things like urgent care work, emergency room. They're doing hospitalist work. Really, I would love to see more of a shift, more of a movement towards quality primary care. And so I'd love for you to start off by telling us about your story, where you did residency, what kind of program it was, and how your life went from there.
Certainly. So Faisel, I trained at University of Missouri in Columbia, Missouri, because the program had a partnership program that allowed me to explore more of my interest around research and around policy. I was trying to combine medicine, research, and policy in some career path. And it was also, it had a lot of rural opportunity. And that's one of the things I fell in love with. I'm from a rural area, but I recognize the value of relationships by working in a rural practice, and the ability to get outside of the academic health center and work in rural settings was a real important thing to me. What I didn't know is that I would fall in love with working in federally qualified health centers there and working in a community health needs assessment related to that. And it was really then in my fellowship when I stayed at University of Missouri to focus on health services research that I got involved in a county-wide community health needs assessment that involved the academic health center, the federally qualified health center, and the health department. And I worked with some fantastic geographers that could translate our clinical data into the footprint of our practices on the landscape. And I realized that was the front end of community-oriented primary care, the ability to define your community and then characterize it. And I thought, this is fantastic. I can now see with clear definition who we're serving and who we're not serving and figure out where the holes in the safety net are in my community. And that actually turned into 2 or 3 different expansion grants for our FQHC. And that was the launch of my finding my niche of how you combine research with a policy approach to improving access to healthcare. And it's what took me to Washington, D.C. to work at the Robert Graham Center, the American Academy of Family Physicians Health Policy Research Center, right out of fellowship, was the idea that I could take this model and expand it. So that's my initial story, and it just turned into a full career.
Wow. So when you were first defining the boundaries, especially in the rural area, I'm familiar. I joined a large FQHC right out of residency as well. They're saying once you're an FQHC doctor, you're always a community doctor. In the urban settings, it's pretty straightforward to kind of lay out the boundaries. But when you're talking over large spaces of area, especially in the rural parts of the country, how would you define those areas?
Well, you actually use your patient data. You use their addresses to populate every census tract around you, and then you rank them to figure out where are the areas that you're serving the most. Um, and Faisal, this became 10 years later. This became a tool that we built for the Health Resources and Services Administration, called the UDS Mapper, that takes the data from every federally qualified health center in the country and shows them their footprint on the landscape, and it helps define the holes in the safety net where FQHC expansion needs to take place. So, and it's fascinating when you show physicians the geography that they're serving. What we found in my own practice and having them estimate their service area is that most physicians overestimate their service area by 100%. They often capture the right geography, but then they expand that boundary by a lot. So getting specific is really helpful for helping them figure out who they're serving and what their social determinants look like.
I love how you're helping identify and talk about the social determinants. Oftentimes we see in our world, I mean, we exist in the similar populations, actually the same neighborhoods as the FQHCs, Chen Med, and issues like home insecurity, food insecurity are really the drivers with our patient population, not only our patient, but most of the country. And so, what are some of the ways that doctors or primary care doctors can help? Most of us in the FQHC world, we didn't have enough resources to look after the neediest populations. What are some of the ways in the fee-for-service system you see that we can help start addressing some of these needs?
So in the system as it is currently, I don't think there are a lot of good ways because, primary care provides more than a third of all visits in the country, yet we draw down less than 5% of total healthcare spend. I mean, and that's down from 6.5% 15 years ago. So we're really starved for our capacity to address anything other than the person in front of us. So, but right now we are working with CMS, the Center for Medicare and Medicaid Services, and several other federal agencies to take a model from New Zealand and the United Kingdom, where you use neighborhood social risk scores to identify the places and the people who are at greatest likelihood of having social need. And you can use that at the patient level. We call it a community vital sign because, like blood pressure, this score says this person may have needs that you need to talk about, and they may have a need for intervention. At the community level, it helps us figure out, is this a solution we should be driving at the patient level or the community level? And so what we've proposed to CMS and that they're quite interested in is, can we use that as a way to channel more funding to practices who care for the people in the most underserved neighborhoods? It's a way of risk adjusting payment with a very specific goal of addressing social need. And that's what we're going to be pursuing over the next 6 months with them.
Wonderful. Now, but is this only working with the FQHCs or really anyone, any private practice? There's so many independent physician associations.
No, so Maryland is experimenting with this with FQHCs, but our goal is to have a policy option for Medicaid and Medicare writ large. So, and it can be fee for service or it could be in a capitated model, so long as it drives more resources to people who are taking care of disadvantaged patients.
That's wonderful.
How do you, I'm just wondering, how do you keep the politicians from playing games as you see in some of the cities you're starting to see gentrification, and so I can imagine that once you start paying practices in a given area more, they're going to they're going to feel fairly entitled to that. And so if you tie it to a geography rather than tying it to the patients, I'm just wondering that I'm sure somebody's thinking about that. I was just wondering what your thoughts are about it.